What's up, Ninja Nerds? In this video today, we are going to be talking about pleural disorders. That includes pleural effusion, that includes pneumothoraxes. You know what? We'll also take a little bit of time to talk about atelectasis as well, because sometimes that can be confused with pneumothorax. So I want to take a quick little moment to talk about that as well. Now, when we talk about these pleural disorders, we're going to go over the types, the causes, the pathophys. That being, we'll talk about pleural effusion first, then we'll talk about pneumothorax, we'll go over atelectasis, we'll go over the causes and the pathophys involved. First one is we're going to talk about pleural effusion. So you have to know the basic anatomy. This isn't crazy. We don't need to go nuts. Basically, you have this layer of tissue, mesothelial tissue, that kind of lines the actual lung tissue. That's called the visceral pleura. Then there's another mesothelial tissue that lines the chest wall, where you'll have your ribs, your cartilage, and then some of the muscles there. That's the parietal pleura. The space that exists between the visceral pleura and the parietal pleura is called the pleural cavity. Now, if fluid accumulates within the pleural cavity, or it doesn't get cleared from the pleural cavity properly, what is that called? That's a pleural effusion. So a pleural effusion is going to be a big whopping chunk of fluid that's developing within the pleural cavity. Now, there's two etiologies or two causes, pathophysiological reasons for these. One is it's due to an increase in fluid production. We're making too much fluid at the capillary level, which we'll zoom in and talk about, right? And it's leaking into the pleural cavity, or we're just not removing the fluid via the lymphatic system because it's all clogged up or blocked up for whatever reason. So let's first talk about the causes that lead to an increased fluid production. Now, when we talk about these, it's really interesting how this happens. There's two processes or two pathophysiological processes. One is called transudative pleural effusions. You increase the amount of pleural fluid in there due to a transudative process. All that means is you're accumulating a watery type of serous fluid in the pleural cavity. Very little proteins, just a lot of watery plasma. Exudative effusions are a little bit different. This is more of an inflammatory process that causes increased capillary permeability and leakage, which leads to proteins, which leads to plasma, which leads to cells, and all of those types of substances leaking into the pleural space. Now, we have those two factors there that lead to an increase in fluid production or accumulation. It's either transudative, which means lots of water, very little proteins, exudative, lots of capillary leakage, fluid, protein, plasma, cells. Let's go over the etiologies or the causes for transudative effusions and then exudative effusions. Now, when someone has a transudative pleural effusion, right, the things that you want to think about, okay, transudative, we know that it's a lot of watery fluid, not a lot of plasma proteins are leaking into it. Okay, one of the reasons for this is due to a high hydrostatic pressure within the capillaries. You know, if you were to really zoom in and we were to take a piece of that pleura, so imagine here's the actual lung parenchyma, that blue tissue, that's the lung parenchyma. Then we had the visceral pleura, which was the one that clinged to the actual lung tissue. And then you had the parietal pleura. So we have lung tissue, visceral pleura, parietal pleura. There's little capillaries that are actually going to exist here. Now, imagine for some particular reason that these capillaries are under higher pressure, hydrostatic pressure. You guys remember that? Hydrostatic pressure is the pressure that is actually going to be pushing things out of the capillaries. So the capillary hydrostatic pressure is really, really high. Now, what would make the capillaries' hydrostatic pressure, the pressure that pushes plasma out of the capillaries and into the pleural cavity, what would make that high? Guess what? If you have a patient who has left side heart failure, their venous pressures on the left side are going to be increased. So fluid or blood that's supposed to be pumped out of the left heart into the aorta will not be pumped properly, and it'll back up into the pulmonary circulation. If it backs up via the pulmonary circulation, these are my pulmonary capillaries. They're going to be under high venous pressure. That high venous pressure will increase the hydrostatic pressure, because hydrostatic pressure is generally related to the actual pressures within that system, that circulation. So if I have high pulmonary venous pressures, the hydrostatic pressure will go up. And that'll cause this fluid leakage into the pleural cavity. And therefore, we'll develop a nice pleural effusion. So high venous pressures could be due to heart failure, or it could be due to the pericardium around it being super rigid and mean and nasty and not allowing for the heart to be able to expand and fill. If the heart can't expand and fill because you have a nasty constrictive pericarditis, we can't fill. It's the same thing as though I'm not going to be able to pump blood out. It's going to back up. If I can't fill properly, the venous pressures on the left side will increase, back up into the pulmonary venous circulation, increase the hydrostatic pressure, and leak fluid into the pleural cavity. Boom, roasted. So we have CHF, constrictive pericarditis. If you really wanted to add another one in there, you could add in like restrictive cardiomyopathy as well. Anything that's going to cause high pulmonary venous pressures from left-sided heart failure is the kind of feature that we want to remember. Here's the other one. Maybe it's not due to high hydrostatic pressure. Remember when we talk about movement of fluid out of a capillary, there's one pressure, this pressure here, right? The pressure that wants to push things out of the capillary. What's that called? We call this the capillary hydrostatic pressure. But there's also a pressure that these capillaries want to use to keep fluid in the actual capillaries. What's that called? That's called the oncotic pressure. The capillary oncotic or capillary osmotic pressure. Now, if the capillary osmotic pressure is designed to be able to kind of keep fluid in the capillaries, if we have a decrease in the capillary osmotic pressure, the ability to keep fluid or drive and pull fluid into the capillaries and not leak out is going to decrease. So this ability to pull fluid in is going to decrease. And so what happens is instead of us being able to keep fluid inside of the vessel, it's going to leak out into the actual pleural cavity. Now, the really, really important question here is that as we decrease osmotic pressure, we decrease the ability to hold fluid in the vessel. So therefore, if we can't hold fluid into the vessel, it's going to leak out into the interstitial space, or into this case, the pleural cavity space. What would be a reason that we would have a decrease in colloid osmotic pressure? The reason would be less proteins in the blood. And you know there's a disease called cirrhosis where you can't make albumin, or a condition called nephrotic syndrome where you urinate out or excrete or eliminate albumin into the urine. Either way, there is a decrease in albumin. And albumin is that protein that helps to be able to maintain colloid osmotic pressure, keeping water or fluid in the actual bloodstream. If I don't have albumin, I can't keep the fluid in the bloodstream and it leaks into the pleural cavity. Those are big things to remember. All right, my friends, that covers the transudative causes. So transudative causes, two kind of features behind this. One, increased capillary hydrostatic pressure from high venous pressures, high left-sided heart pressures, or decreased colloid osmotic pressure due to decreased amounts of plasma proteins within the bloodstream. All right, exudative effusions are a little bit different. Now, what I want you guys to remember for exudative effusions is the same thing. Here's your actual lung parenchyma. Here's the capillaries, here's the visceral pleura, here's the parietal pleura, yeah? In a patient who has an exudative effusion, the pathophysiology for these, if you will, is all the same, so that makes it really easy. The whole concept here is that these capillaries are super leaky. They could be leaky because of inflammation. Generally, that's the kind of the most likely cause. There's inflammation. And when that inflammation occurs, it causes the capillaries to become super leaky. They're not as well kind of like tight and controlling of permeability as they usually are. So now they're super leaky, super permeable. And if you increase permeability, if you increase the capillary permeability, guess what you're gonna do? You're gonna allow for a lot of things that shouldn't be able to leak out of the vessel to leak out of the vessel, and subsequently, right into the pleural cavity, my friends. What are some of those things that are going to leak right into the pleural cavity? Plasma will be one. You know what else will leak in there? Proteins, large plasma proteins that are usually not able to get out because usually the capillaries are a little bit more selective and don't allow large plasma proteins to leak out. But now, these are super permeable. Proteins can leak out. Cells can leak out. So like white blood cells, red blood cells, all those things can leak out of the capillaries and into the pleural spaces. So when exudative effusions, there's an increased capillary permeability due to inflammation in the area. That inflammation increased the capillary permeability, fluid, protein, and cells will leak out into the pleural cavity. That's much different from a transudative effusion. Now the question that comes with this is what leads to this inflammation and leads to capillary permeability, which allows for fluid, protein, and cells to leak into the pleural cavity. One reason, pneumonia. If patients develop pneumonia, there's an infection. If there's an infection in that area, if I were to zoom in, that infection is going to cause the bacteria to lead to inflammatory responses, increase the capillary permeability, and you develop a effusion. You know what this is actually called? It's really important to know this. Whenever you develop an effusion due to a localized area of pneumonia, we call this a Pneumonic effusion. This is a little bit different than what we'll talk about later called an empyema, which is when the infection, the bacteria, actually spread into the pleural cavity and they develop like pus within the pleural cavity. That's called an empyema. The next one is malignancy. Malignancy can cause localized inflammation, increased capillary permeability as well. Another one, and if you have a patient who has RA, so rheumatoid arthritis or SLE, or some of the vasculitides like what's called Wegener's or GPA, so granulomatous polyangiitis, or Churg-Strauss syndrome called eosinophilic polyangiitis, there's a lot of autoantibody or autoantibody kind of attack onto the lung tissue and the capillaries in that sense that it will cause inflammation. It's going to attack the lung parenchyma. When it attacks the lung parenchyma, it'll lead to localized inflammation. That inflammation will increase capillary permeability and lead to pleural effusion. So think about that as well. So we got pneumonias, or any kind of infection really. Think about tuberculosis as well. Malignancies, collagen vascular diseases like RA is a big one, SLE, and then your vasculitides like Wegener's and Churg-Strauss. Here's another really interesting one. In situations where you have massive systemic inflammation, sepsis would be one particular reason. Another really big one is pancreatitis. They may ask this on your exam. And pancreatitis is such a massive amount of inflammation and so much cytokine release that these cytokines, as they move through the actual vasculature of our body, they get to the pulmonary vasculature and increase the capillary permeability of these vessels and cause leakage, which can lead to pleural effusions. So if a patient has pancreatitis, some type of systemic inflammation from pancreatitis, think about this as a potential cause of their pleural effusion. That's a big one. Now the last one's a really interesting one because it's a mixture of transudative and exudative effusions. This is a pulmonary embolism. Now, when a pulmonary embolus occurs, imagine here blood flow is moving through this pulmonary vessel and then it stops because it hits this big old clot. The pressure just before that clot is going to be high. If you increase the pressure in that portion there, what's going to happen to the capillary hydrostatic pressure? It's going to increase. If capillary hydrostatic pressure increases, what happens to the movement of plasma out of the capillaries and into the pleura? It increases. So then fluid will leak out into the pleural spaces. So in an early PE, it's transudative. But here's what's interesting. Our body tries to adapt. And so what it does is now that this clot is here, there's going to be certain types of immune system cells and endothelial cells of our actual vessel who will try to make the vessel bigger and dilate it. And so in order for me to be able to dilate this vessel, there's going to have to be some type of like chemical mediators that'll help to be able to allow for this vasodilatory response. And so because of that, there's going to be these chemical mediators that get released by endothelial cells and other types of immune system cells. If inflammatory mediators are released, what do they do to the capillary permeability now? They increase it. If you increase the capillary permeability, what's going to happen now? You're going to allow for fluid and proteins and cells to leak out of the capillaries into the pleural space. What is that now called? An exudative effusion. So in the later stages of a PE, it tends to present more like a exudative effusion. All right, so I think we have a pretty good idea about transudative versus exudative and how these leads to increased fluid production in the pleural cavity leading to a pleural effusion. The next thing here is if we have, let's say, a normal amount of pleural fluid there. So the amount of pleural fluid that's being produced is normal. There's no increased pleural fluid production or accumulation in that sense. The problem is that we have pleural fluid that's being produced. It's natural for us to make pleural fluid. The problem is that we don't clear the pleural fluid. So lymphatic vessels are actually connected to the pleural cavity and they should be able to naturally pull some of the fluid out of the pleural cavity and then take it to the lymphatic vessels, which then empty it back into our circulation. Pretty cool, right? Well, what happens if that lymphatic vessel that's supposed to take this pleural fluid and clear it starts to become obstructed, damaged, compressed for whatever reason? That would be problematic. We wouldn't be able to clear the fluid and pleural effusions will start to develop. Pretty straightforward, right? So think about lymphoma, right? Or maybe not just lymphoma, but if you have some type of malignancy. So let's imagine that you have like a pretty big like cancer here and it's compressing on large lymphatic vessels nearby. So maybe it's not necessarily just lymphoma, so big kind of lymph nodes that are chalked up with all of this kind of like cancerous tissue that's preventing the actual movement of lymphatic fluid, but maybe you have some type of cancer that's compressing nearby lymphatic tissue or lymph nodes and preventing them from being able to now allow for normal lymph flow. That makes sense, right? The other really big one that they love to present on the actual test, though, is there's a structure here called the thoracic duct. Now, the thoracic duct is kind of this like large lymphatic vessel that's supposed to empty lymphatic fluid that it gains into the area where the brachiocephalic vein, the left brachiocephalic vein, and the left internal jugular vein fuse. The thoracic duct will empty lymphatic fluid there. Now, what if, for whatever reason, during a surgical procedure, I damage the thoracic duct? A central line procedure, I'm doing some type of surgery near this area of the neck or the chest, and I damage it, I injure it. If that happens, am I going to be able to empty all of that lymphatic fluid that it's going to be collecting from, guess who? From this area of the pleural cavity. So it's going to be picking up some of that fluid from the pleural cavity. So now all of this pleural fluid that's supposed to be moving up and dumping into the thoracic duct, well, the thoracic duct dumps into the venous system, is no longer. And so now all that fluid that is supposed to pick up just backs up. And we aren't able to clear that pleural fluid, and that leads to a massive amount of fluid that can accumulate within the pleural cavity. Now, there's a special term that you need to know for this. So if for some reason the lymphatic vessels are clogged up because someone has lymphoma, or they have a cancer that's pressing on that actual lymphatic tissue, or they have the thoracic duct that's being damaged or compressed for whatever reason, then that pleural fluid will accumulate lots of things that contain lymphatic structures, actually lymphatic contents. You know, lymph is really, really rich in fatty molecules such as triglyceride and cholesterol because it carries these things called chylomicrons. If for whatever reason we are able to clear the lymphatic fluid, it starts backing up. Some of the lymphatic fluid starts backing up into the actual pleural cavity now because it's being compressed or destroyed, or for whatever reason those lymphatic structures are being compressed and it's backing up into the actual pleural fluid. You'll contain things like triglycerides and cholesterol, fatty material within the pleural fluid. And we call this a chylothorax, which is when there's lots of lymph fluid that is accumulating within that pleural effusion. All right, so we've covered pleural effusions now. That's not the only pleural disorder that we got to talk about. Let's move on to pneumothorax. Pneumothorax is another kind of disorder that involves the pleura. So again, in this situation, you have the visceral pleura, the parietal pleura, but now there's air that's actually located between the visceral and the parietal pleura within that pleural cavity. When there's air, it's called a pneumothorax. Now, a pneumothorax is really interesting. Whenever you have a pneumothorax, you want to think about the potential causes, right? So it's primary or secondary. And that may sound like, okay, well, what the heck does that mean? So primary pneumothorax means that there really is no underlying lung pathology really there. It just happens to be in patients who may be a little bit more susceptible. And what are these patient population that you have to be able to recognize off the clinical vignette? So if they present to you, hey, a patient has a pneumothorax, and the little bit about their history and their epidemiology is that they're very tall, thin, young, male, who also has a little bit of smoking and has a history of a very specific connective tissue disease. This is called Marfan syndrome, Ehlers-Danlos syndrome. If you see that, these patients, due to shearing forces near the apex, because they're so tall, they're thin, and again, they may have a little bit of weakness of their connective tissue, the shearing forces at the apex can create these little bubbles of lung parenchymal tissue called blebs. So they're called subpleural apical blebs. And this happens in tall, thin, young males who smoke and maybe have an underlying connective tissue disease like Marfan and Ehlers-Danlos. What happens is, for whatever reason, these blebs may rupture. And whenever they rupture, air can then enter into the pleural cavity and produce this apical pneumothorax. So these patients tend to be more susceptible to pneumothoraxes at the apex due to the shearing forces and the subpleural apical blebs that they may have due to these very specific factors. Now, another patient population is they may say, okay, this patient has an underlying lung disease. If they have an underlying lung disease or there's some type of trauma, it leads you to think, okay, now their pneumothorax is due to some underlying issue, disease process. One thing is COPDers. Look for disorders that cause hyperinflation. If there's a problem where you aren't able to get air out of the lungs because maybe the bronchioles are collapsing, or because you have a mucus plug, or because they're bronchoconstricted and you can't get air out, the lungs will hyperinflate. As they hyperinflate, they have higher risk of forming bullae. And these bullae can possibly rupture. And if they rupture, they can empty air right into the pleural cavity. You see this very, very predominantly in COPD. More specifically though, which one? Do you guys remember from the obstructive disease? emphysema, so don't forget that. Another one is, what if you have some type of disease process that's near the pleura, it's involving the lung parenchyma that's near the pleura, and it's an infectious process that's eating and chewing away at the tissue, and it happens to chew just close enough to where it gets to the visceral pleura, chews through it and creates an opportunity for air to enter from the lung parenchyma right into the pleural cavity. Or you have a malignancy, and the malignancy is continuing to grow and grow and grow, and it grows into the visceral pleura and creates an opportunity for air to enter in to the pleural cavity. So think about hyperinflation disorders, specifically emphysema. Think about necrotizing types of infections. PJP is a really big one, tuberculosis, or think about malignancy. Now, the last situation here is maybe it's not due to an underlying lung disease process, it's due to some type of problematic issue that either we did to the patient or the patient did to themselves. So if someone gets in a trauma, like they have a traumatic event, they get stabbed, right? They take a tomahawk to the chest, and we put a hole between their actual chest wall. Now I have an opportunity for air to be able to leak into that pleural cavity. If I hit them with the baseball bat, I break a rib, and that breaking of the rib creates enough to be able to shear and rip through parts of the actual pleura, creating an opportunity for air to leak in. Boom, that's another issue. So any kind of blunt or penetrating trauma can create an opportunity for air to leak into the pleural cavity. Right? Or if you have some type of blunt force trauma and it's enough to be able to cause enough lung damage that opens up an opportunity for air to either move in through the lung and out into the pleural cavity. So either way, think about trauma. The other reasons are iatrogenic. It's something that we did to the patient. Sometimes when patients are on mechanical ventilation, we can increase the pressure within their airways because we want to keep the alveoli open to be able to allow for them to better oxygenate. But sometimes as we increase the pressure within inside of the airways, it can cause enough that it can really open those alveoli enough that they rupture. And if it ruptures enough, it can create an opportunity for air to leak into the pleural cavity. This is usually seen in patients on invasive mechanical ventilation where you're increasing their positive and expiratory pressure. The last one that I want you to remember is during procedures. So if you're actually doing a central line where you're kind of coming down and trying to hit the IJ, but you come down at a very poor angle and you end up hitting the apex of the lung, or you're doing a subclavian central line placement and you just end up kind of having a bad angle and bringing the syringe off the horizontal and hit the lung. These are other things that can cause pneumothoraxes that can be iatrogenic. And the last one is if you're doing a thoracentesis. So sometimes if you're doing a thoracentesis and you're actually trying to go in and pull off fluid for a patient who has a pleural effusion, and guess what? You just put the needle in just a little bit too far, hit the lung, it's enough for air to leak out of it and cause a pneumothorax. All right, so these are big things to think about when you're talking about a patient who has a pneumothorax, air within the lung. It's either primary, nothing really truly wrong with the lungs, it's just they're highly susceptible because these subpleural apical bleps, tall, thin, young male smoker, Marfan, Ehlers-Danlos. Or secondary, hyperinflation, think emphysema. Necrotizing infection, think TB or PJP. Malignancies, or some type of traumatic, blunt force trauma, penetrating trauma, mechanical ventilation where you're increasing the PEEP, or procedure-related central line placement, such as an IJ or a subclavian, and lastly, a thoracentesis. Now, there's one more thing that we have to talk about with pneumothoraxes that are really kind of an important terminology, and that's open pneumothorax versus a tension pneumothorax. Let's come down and talk about that quickly. All right, so an open pneumothorax, whenever you hear this terminology of an open pneumothorax, maybe it's some type of chest wound, right? So they have a penetrating trauma, they got stabbed, they got hit with a tomahawk, and it creates a hole in their chest wall. What happens is air can then move into the actual pleura during inspiration. So they take a breath in, the air can actually come in through the trachea and into the lung itself, but it can also come in via that wound in the chest. But during expiration, normally we want air to leave the lungs. But guess what? It's also within the pleural cavity. So if you have some type of hole here, whatever it may be, there's a hole within the lung and air is moving into the pleural cavity during inspiration, whether it be from the lung into the pleural cavity or through a defect in the chest wall into the pleural cavity. That's happening during inspiration. During expiration, when they're supposed to have air leave their body or leave their pleural cavity, if there's an open chest wound, the air can leak out during expiration, or some of the air may move into the pleural cavity and then again out of the lungs during expiration. But the whole thing to remember is that an open pneumothorax has a two-way flow, in during inspiration, out during expiration. So it's not necessarily as dangerous as the ominous and fearful tension pneumothorax. With the tension pneumothorax, if a patient takes a breath in during inspiration, let's say that they have a chest wall defect, air will come in during inspiration, but they have like this little valve, if you will. So a valve will allow for it to open during inspiration when they take a breath in. But whenever they get ready to take a breath out, the pressure inside of that cavity may increase enough that it actually closes off that little opening. And now the air that's supposed to be able to exit out during expiration does not. So air will only flow in during expiration, will not flow out during expiration. Why is that more fearful? Because in this, I have air moving in and out. There's not as much air that's accumulating within the lungs after that entire inspiratory-expiratory cycle. In a tension pneumothorax, air is only moving in. It's not going out. So more air will accumulate very rapidly within this pleural cavity and lead to a lot of compression and displacement and midline shift because of how pressurized that pneumothorax will become. So that's a big thing to remember. Open pneumothorax, bi-way flow, okay, two-way flow. Tension pneumothorax, only a one-way flow because the valve will kind of close it off. Imagine like a valve, if you will, within the chest wall that blocks off the flow during expiration, pressurizes that pleural cavity, and starts really pressing on the lungs in nearby structures. All right, that covers pneumothorax. What I want to do very briefly is talk about something that most people can confuse with a pneumothorax, which is atelectasis. All right, so the next one is atelectasis. So sometimes people say, is atelectasis the same thing as a pneumothorax? It is not necessarily the same thing. The reason why is atelectasis is kind of like small alveolar, bronchial kind of alveolar collapse. Now, the reason why the alveoli and the bronchioles collapse and make the lung appear smaller, like it's hypoventilated or it's smaller than it usually should be, has many different causes or reasons. But the basic concept is, if I were to have this patient's lung, you see how their lung, if you look at the pleura, it's not separated. There's not a big fluid that's accumulation within there. There's not a lot of air that's accumulating in there. There could be a lot of reasons that patients can develop these kind of like smaller collapsed looking lung. What are the reasons why? Because if we were to really zoom in at the actual kind of like small cellular level here, you can see here's like a small bronchioles and they're extending into these alveoli. These alveoli, look at them, they're all tiny. You see how all these alveoli look all collapsed? That's the big concept in atelectasis, is that there's a lot of alveolar collapse. Now the question that kind of comes up here is what actually leads to multiple alveolar collapse, which if you have a bunch of alveoli, that's making up the lung parenchyma. If they're all collapsing, won't this area of the lung tissue shrink because of the alveoli collapsing? Yes. But the question is what causes those little bad boys to collapse? There's a couple different reasons. One is you have an obstruction within the airway. If I have right here at this bronchial an obstruction, now air that's supposed to be able to move into this lung is not able to move into the lung. Because I have a big obstruction, air will move nicely into this lung, but whenever it gets here, boom, hits a big old obstruction. Air will not fill all these alveoli distal to that obstruction, so therefore the alveoli collapse. If multiple alveoli collapse, the entire lung will start to collapse and get smaller. What could be reasons why you would have an obstruction there? A big fat mucus plug that's actually accumulated there. Or you have a foreign body, you swallowed a penny or something of that nature. Or there's a big obstructive, completely obstructive tumor. Those would be the particular reasons. The second one is really interesting because it leads us perfectly with what we just talked about. If patients accumulate lots of fluid or air within their pleural cavity, and now this is supposed to not be pressing on lung tissue, but guess what? You got all this fluid and air, now it's just going to start smashing and pushing on those alveoli, collapsing alveoli after alveoli. What will that do to the actual lung parenchyma? Shrink it. So the alveolar tissue will start to shrink or collapse. That'll make the lung appear smaller. In that situation, then it could be due to a pleural effusion or pneumothorax that is compressing the lung tissue, causing the alveoli collapse. But you get the difference here between a pneumothorax and atelectasis. The last two are very interesting, but they're not super high yield. One is you could have so much fibrosis of the lung tissue. If your lungs are crazy fibrotic, their ability to whenever you inhale, take a deep breath in and expand is very poor. If you have hypoventilation, you're not taking in good inspiratory volumes, are you going to inflate the alveoli? No. If you can't inflate the alveoli, then what's going to happen? They're not going to expand. But you know what else? If you have lots of fibrous tissue, guess what? That fibrous tissue and elastic tissue will recoil like a son of a gun. And so whenever you exhale, you'll exhale a ton of air out, but you barely had any air in your lungs. And so it'll just make those alveoli so small because you're not taking a lot of air in. And when you're exhaling, you're pushing a lot of air out, leaving very little air remaining in the alveoli. Their residual volume is low. You see this classically in interstitial lung diseases. The last one, not super high yield at all, but I want you guys to know, just because it may come up possibly, is adhesive atelectasis. And this is basically, there's these little proteins here called surfactant. And surfactant helps to be able to reduce surface tension. And if basically, surface tension is basically a kind of a tension that wants to collapse the alveoli. Surface tension increases, alveoli want to collapse. If I have a decreased amount of surfactant because I'm washing it out in such situations like infant respiratory distress syndrome where they don't make it, or ARDS where I'm having so much inflammation that I'm clearing a lot of that surfactant out. If I decrease surfactant, it increases surface tension, increases collapsing pressure, boom, the alveoli collapse. It'll make these portions of the lung parenchyma smaller, make the lung look smaller. Those are the probable causes or the reasons why patients develop atelectasis. Now understand that. Now that we've gone over this, let's go over how will these patients typically present. Atelectasis, for the most part, is usually asymptomatic. So we're going to primarily focus on pleural effusions and pneumothorax. All right, my friends, so now features, complications of pleural diseases. Now, if a patient comes in, right, it may be somewhat difficult to differentiate a pleural effusion versus a pneumothorax. So what I want to do is take them and present them side by side so you can notice some of the similarities and the very minor differences that they could try to trip you up on the clinical vignette. Now, when a patient has any kind of injury to the pleura, whether it be fluid irritating the pleura, whether it be due to injury that's actually causing air to accumulate within the pleural cavity, there's irritation of the pleura. Whenever there's irritation of the pleura, this can produce a pain over the chest. But it's very interesting because this pain is usually during breathing. So they have pleuritic chest pain. So the pain really hurts when they take a deep breath in. Look for that on the clinical vignette, but both of them will have that. What's a differentiating feature? One of the big things is that when a patient lays flat and they have a pleural effusion, it kind of causes the pleural effusion to kind of layer out, and that can affect more alveoli. And because of that, their pleuritic chest pain, or it can actually interact with more pleura, if you will. If it interacts with more pleura, it can cause more of a pain, particularly that gets worse when they're laying down flat. So look for them to say, I have a lot of pain when I'm taking a breath in, but it's even worse when I'm laying down flat. That's kind of the key feature. Another one, kind of going off of the pain that they may present with, which is one of the differentiating factors here, is that in pleural effusions, they may irritate the nerve of the diaphragm. So pleural effusions usually love to accumulate near the actual bases of the lungs. And so because of that, they may agitate the phrenic nerve of the diaphragm. And the phrenic nerve, they usually can produce referred pain when it's actually agitated, which goes to the shoulder and sometimes into the neck region. And so if they complain of same side, maybe they have like some pleuritic chest pain on the right side, they may also have associated right-sided shoulder and neck pain in pleural effusions. So look for pleuritic chest pain worse when they're laying flat, and referred pain from phrenic nerve irritation, shoulder and neck on the same side. All right? That's the big things. Now, a lot of the other stuff is the same. They have fluid or air in their lungs, which is affecting the lung from being able to completely expand. They'll have unilateral decreased chest expansion. So when they take a breath in, and you would actually kind of measure the actual separation of your thumbs as they take a breath in, you'll notice that one side will actually only move a little bit. This is one of those tests that you can do in your physical exam. You take your actual thumbs on the spinous processes and have them take a deep breath in, and usually your thumbs will kind of move out. If one side, let's say the right side, is filled with fluid or air, this will only move a little bit. This one will move a lot, and this one will move only a little bit. All right? So there could be decreased chest expansion on the affected side. Also, if you're listening and auscultating, there's lots of fluid or air that's affecting the air that's moving down through the bronchial system into the alveoli. You're not going to be able to hear that as well. So their breath sounds will also be decreased bilaterally. I'm sorry, and in this case, they'll have decreased breath sounds in both of these conditions. So decreased unilateral chest expansion, decreased breath sounds. What else? If I were to go and actually kind of put my hypothenar eminences on the back of their chest wall and have them say 99, 99, it's looking at the vibrations that are actually moving through the chest wall. If they have lots of fluid or air that's altering that movement of vibrations, I'm going to feel it a lot later than I normally would with normal lung tissue. So both of these will have the decreased tactile fremitus. So again, both of them will have decreased unilateral chest expansion, both of them will have decreased breath sounds on the affected side, and both of them will have decreased tactile fremitus on the affected side. One of the other differences though is whenever you go and percuss. So if you take and you percuss over the chest wall, whenever there's lots of air, it produces more of a drum or tympanic type of sound or a very hyper resonant type of sound to percussion, whereas if there's a lot of fluid, it's more dull to percussion. So these are some of the key ways of being able to differentiate the signs and symptoms of patients with a pneumothorax versus a pleural effusion. Now, the other really important thing that you may come up on the exam and you have to be able to notice is if you know a patient has a pneumothorax or they present pleuritic chest pain, decreased chest expansion on the affected side, decreased breath sounds in the affected side, they have hyperresonance to percussion, they have decreased tactile fremitus, right? All of these types of features here that really kind of point towards a pneumothorax. And then you notice some other really concerning features. You start noticing that they're having a lot of pressure that's developing on that pneumothorax, that it's starting to become pressurized and push things over to the contralateral side. So let's say that this patient has a right pneumothorax. You'll have maybe originally decreased breath sounds. You'll have, what else? Hyperresonance to percussion. You'll have decreased chest expansion on the affected side. You'll have decreased tactile fremitus, and they'll have right-sided pleuritic chest pain. If you also start to see problems where this pneumothorax is becoming so pressurized it's shifting things from the right to the left, you'll see some complications. One is it'll start pushing the trachea to the contralateral side. So you'll see tracheal deviation to the left side in this patient. The other thing is that if it gets so much air in here, it can really cause the breath sounds to be almost absent. So it may be decreased to almost completely absent on the affected side. The other thing is that it's going to start pushing and mashing on the superior vena cava or the inferior vena cava. Superior vena cava is the more important one though. If it compresses on that puppy, what's going to happen? Are you going to be able to fill the heart? No. If you can't fill the heart, it's going to back up via the brachiocephalix and into the jugular vein. So it'll cause jugular venous distension. It'll also start compressing on the right side of the heart. If I compress onto the right side of the heart, I can't fill the heart properly. If I can't fill the heart, I develop a drop in preload. If there's a drop in preload, there's a drop in stroke volume. If there's a drop in stroke volume, there's a drop in cardiac output. If I drop my cardiac output, I could develop hypotension. So look for this as a potential etiology of what kind of shock? Obstructive shock. So these are the things to think about when a patient has a tension pneumothorax. All right, so the last thing that I want you guys to think about here is if you have another patient who has some type of pleural effusion or pneumothorax or atelectasis, they may not all have hypoxemia, rip-roaring hypoxemia where you put on the pulse ox and it's like 22%. That's not always the case. Sometimes it's a very small pleural effusion, small pneumothorax, a little bit of atelectasis. It's not going to cause that much hypoxemia. But as you develop a big whopping pleural effusion, a big pneumothorax, a big severe atelectasis where multiple alveoli are collapsed, then you can start to see hypoxemia. So if you think about this, here's a normal alveoli, here's a collapsed alveoli. As we collapse multiple alveoli, think about what I'm going to do. I'm going to be able to fill this alveoli very well, and I'm not going to be able to fill this alveoli with enough oxygen as usual. So because of that, oxygen will move very easily into this alveoli into the pulmonary capillary blood, and CO2 will move very easily from the pulmonary capillary blood into the alveoli. But in this situation, there's very little oxygen that's moving into the alveoli. Okay? And because of that, the amount of oxygen that's going to be moving into the pulmonary capillary blood is going to be less. This will lead to hypoxemia. Now, what is the complication of hypoxemia? So obviously, when you put these patients on their pulse ox, you'll see a decrease SpO2. So you'll start to see a low SpO2. Here's the other thing. When patients have low oxygen saturation, they can develop reflexive tachycardia and tachypnea. So they can increase their respiratory rate because what their body says is their sympathetic nervous system says, oh man, they're hypoxemic, they must not be ventilating well. I need to have them breathe deeper and breathe faster to bring more oxygen to be able to allow for them to move oxygen to the pulmonary capillary blood better. That's one reason. The other one is if I increase their heart rate, I will try to increase their cardiac output, increase the pulmonary blood flow to the lungs to get better perfusion, to pick up that oxygen, and so they become tachycardic. So look for these potential findings in patients who have severe atelectasis, severe pneumothorax, and severe pleural effusions, where they may develop hypoxemia, tachypnea, and associated dyspnea. That may be a very, very common feature. So look for tachypnea or dyspnea, and maybe even tachycardia with severe disorders of this nature. Okay, now let's talk about diagnostics. Okay, so whenever we have a patient who has a pleural disorder, obviously when we talk about diagnostics, the key test that we're going to need here is first off, starting off with a chest x-ray. Chest x-ray is going to be great. If a patient's coming in with hypoxemia, they're coming in with tachypnea, dyspnea, pleuritic chest pain, they have decreased chest expansion on the affected side, they have some type of abnormality with decreased tactile firmness, decreased breath sounds. Again, all of these features, you're going to get a chest x-ray off the get-go. When you get the chest x-ray, maybe you take a look at it, you're like, oh, there it is, there's a big fat pneumothorax. Oh, there it is, there's a pleural effusion. Oh, there it is, there's the atelectasis. Maybe if it's not as obvious and you want to get a better look, then you can really kind of get a better global picture with a CT scan of the chest. And we'll take a look at a lot of images that'll actually show us atelectasis, pleural effusions, and pneumothorax. Let's go ahead and take a look at those now. All right, so if we take a look at some chest x-rays, some CT scans of some pleural disorders, what are we going to be looking for? Well, the first thing is with a pleural effusion. Normally, when you look at a chest x-ray, you should see this as your diaphragm, right? So this is one of the hemidiaphragms, in this case, the left hemidiaphragm. And then what happens is it kind of creates like this little angle here, right? So this is called the costophrenic angle. So you should be able to see a nice crisp costophrenic angle. What happens is when you lose that costophrenic angle, there could be two particular causes. One is there could be an opacity like an infection, like pneumonia, or it could be a pleural effusion. In this situation here, we see that we can't even see our costophrenic angle. It's blunted, it's blurred, it's not present. So is it a pneumonia? Is it a pleural effusion? One of the key features here for pleural effusions is when you look at it, it has kind of like this meniscus type of thing here. So you see how it kind of starts here and works its way up like this. That's the meniscus sign. Very, very common in pleural effusion. So this patient has a pretty decent size right pleural effusion here that's kind of blocking off our costophrenic angle, and again, a beautiful meniscus sign. So that's what you would be looking for on a chest x-ray for a pleural effusion. Now, let's take a look at the next thing, which would be a pneumothorax. All right, so we take a look here at this chest x-ray. We have a patient who we suspect has some type of pleural disease. We get a chest x-ray, we take a look here. Obviously, you can see the right hemithorax and you see the left hemithorax. You can see the right hemidiaphragm, you can see the left hemidiaphragm. A little blurring of this costophrenic angle, though. It's hard to kind of really make it out crisply, but you can definitely see it better than the prior chest x-ray. One of the things that's really interesting, though, is that whenever you're looking at the lungs, the next thing you should always look for, especially with pneumothorax, is start at the apex and look for really dark areas of lung, and more specifically, look for the absence of lung markings. So you can see how all of this is kind of like a hazy gray, but you can see some lines that are working all the way out to the periphery, all the way from the apex down to the bases. Now start over here. Whoa, look at this. You see how it's all dark, and you see how you can see the actual lung tissue here. You can see the visceral pleura that was pried away from the parietal pleura here on the chest wall. You see how you can see the lining of that? It's pried away, and all of this is really dark. On chest x-rays, any kind of like radiograph like this, usually anything that's going to be lots of air content will be very dark on the chest x-ray. So you can see here really dark type of like appearance here, because this is all airs and absent lung markings. I'm not able to see. You see how the lung markings here usually would extend all the way out to the periphery. It's not there, and I see a big left pneumothorax. All right, so that's what we would see there. Now let's take a look at a chest x-ray of a patient with atelectasis. All right, so when we look at a chest x-ray of a patient who has atelectasis, one of the big things that you want to be looking for is generally some degree of like smaller lungs, but sometimes whenever the lung collapses, whenever the alveoli collapse, what happens is all the alveoli get collapsed and the lung kind of just clumps up. And whenever you have lung that kind of clumps up, it appears more dense. And sometimes it kind of gives like these little dense appearances. And you see how right here we see all the lung tissue. It's well aerated here, well aerated all the way over here. But at this point right here, like right middle lobe, if you will, we can see it's kind of like dense. You see how it's way more dense right here in comparison to this part of the lung tissue of the right upper lobe. This right middle lobe looks like it has a pretty good atelectasis, like it's collapsed. And whenever it collapses, it gives a very kind of like whiter type of appearance because now it's a little bit more dense and consolidated in that area. So this would be one of the potential signs of an atelectasis, particularly I would say of the right middle lobe. Now, one of the really interesting things that I really want you guys to understand here is when we're talking about atelectasis, one of the really cool things that you can see is that sometimes if there's significant, severe atelectasis, like due to a mucus plug that's kind of obstructing one of the bronchi, let's say it's like the primary bronchus on one side, all the air on that entire side will be absent and it'll just start to really kind of condense and it'll white out the entire lung field that's being affected. Let's take a look at that. All right, so the next one here is this is a really terrible atelectasis. And one of the key things that I think is very helpful in differentiating a chest x-ray with a severe atelectasis from a comparison to like a pleural effusion or like a tension pneumothorax is that in a tension pneumothorax or a very large pleural effusion, what happens is the fluid or air on that side, let's say in this case it was on the right side, would push the trachea to the opposite side, contralateral deviation. But in this patient, look, you can't even make out the lung tissue. And you see that the trachea is deviated to the same side as where it's all whited out. So this is severe atelectasis, and it's likely due to a mucus plug of like the right primary bronchus that got plugged up for some particular reason, and now no air is getting into this entire right lung, that an entire lung will likely collapse. And whenever it collapses, it gets super, super dense and consolidated and gives off this whiteout type of appearance. And then on top of that, if you ever see the trachea deviated to the same side as the whiteout, that's also a very common finding of atelectasis. This is a very common one. Definitely put this one into your memory, guys. All right, that covers the chest x-rays. Now let's take a look at some CT findings of some of these types of pleural disorders. All right, so here we have a patient who is obviously intubated. You can see the endotracheal tube in their trachea. But what we want to look for here is as we scan through the CT scan, we're going to work our way from the apexes downwards. Whoa! Look at all this. This is all normal lung parenchyma of the right lung. This is all normal lung parenchyma of the left lung. But you see all this like kind of like dark consolidated structure here in the posterior parts of the lungs. Look at all that. That's all fluid. This is a massive bilateral pleural effusion from the apexes all the way down to the base of both lungs. So this is a massive bilateral pleural effusions. And so this is likely due to severe heart failure, because usually bilateral pleural effusions, it's more likely to be transudative. And so that's a big high yield fact. If you see patients with bilateral pleural effusions and massive pulmonary edema, they have pulmonary edema here, it's likely due to a cardiogenic source. So it's likely transudative, such as CHF. Bilateral pleural effusions are more common with transudative causes such as CHF than exudative. Exudative is usually unilateral. All right, that's one view, but just to give it another appreciation, let's take a look at this view. Look at this. This is insane. You can see all of the pulmonary edema, but you can see this massive pleural effusion that they have in this side and the massive pleural effusion that they have here on this left side, because we're working our way from kind of anterior to posterior. If you really wanted to get another look here, look at this sagittal view. Look at this. That's all pleural effusion, all of this. From this point here, from the apex all the way down to the base, this is all pleural effusion. And that's on both sides. So pretty huge. And again, likely the cause for this patient is cardiogenic. So they had pulmonary edema and big bilateral pleural effusions. All right, let's take a look at another image, particularly of a CT, to look at a pneumothorax. All right, so here we have an image of a pneumothorax, and you guys are going to notice it right away. We're working our way from below. And look, you see how there's all this air and like the subcutaneous tissue? It's very interesting. A lot of air in that subcutaneous tissue there. A lot of subcutaneous emphysema. And then, whoa, here's right lung. Here's like a piece of the left lung. And there's all black. What I tell you shows up black on chest x-ray, CT scan, air. There is a ton of air that's separated the visceral pleura from the parietal pleura. This patient has a massive left hemithorax, left-sided pneumothorax. And the likely cause of this is due to emphysema. They likely had a severely large bullae due to their underlying COPD that actually ruptured into the pleural cavity and created a decent sized pneumothorax. And then the other thing is that sometimes if that air can travel and splice along the edge of the bronchus, it can enter into the subcutaneous tissue and cause subcutaneous emphysema. Sometimes they call it like Hammond's sign. So you get the crunchiness of the chest, and that's usually due to all of the air that kind of gets deposited into the subcutaneous tissue. So this is definitely a pretty severe pneumothorax with lots of subcutaneous emphysema. But again, that just highlights these findings here. All right, that covers the images. Let's get back to the whiteboard, and now let's go back over some other things like thoracentesis. So now we've been able to diagnose atelectasis and pneumothorax and pleural effusions. But we're not done with pleural effusions, because guess what? Pleural effusions, we also really high yield here. I need you guys to pay attention at this point. Probably one of the most important points of the lecture for pleural effusions is that we also need to do a thoracentesis, a diagnostic thoracentesis. Now, when would we not do this? If we know that the patient has an underlying history of congestive heart failure, they have history of bilateral pleural effusions of some nature, then we might not even go and do a thoracentesis because we have an actual kind of like likely cause of their pleural effusion. But if it's a little bit odd, their CT, their chest x-ray shows some concerning things and we don't really know, they don't really have a significant history of CHF or cirrhosis or nephrotic syndrome, anything that would kind of make me think a transudative pleural effusion, then I'm starting to be concerned, could it be an exudative effusion? Could it be a nasty pneumonic effusion? Could it be an empyema? Could it be malignancy? Could it be tuberculosis? Could it be a collagen vascular disease? Could it be pancreatitis? Could it be all these different things? And so the only way that I can do that is to start off and do a thoracentesis, pull some of the fluid off, and then send it and order specific tests that'll then kind of lead me into the gateway to say either this is transudative or exudative. And this is where we come with what's called Light's criteria. So we have a patient who gets a thoracentesis because they have a big whopping pleural effusion, and we can't chalk it up to CHF and him having a past history of pleural effusions, which is a very common cause. If that's the case, then we're going to follow Light's criteria. So what Light's criteria says, we're going to get the thoracentesis, we're going to send it off, and we're going to look at a couple different things. We're going to look at the serum LDH in comparison to our pleural LDH. And then what we're going to do is we're going to look at the serum protein in comparison to the pleural protein. And we're going to develop some ratios. If we take the ratio between the amount of LDH that's present in this pleural fluid in comparison to the serum LDH, and it is greater than 0.6, that ratio is greater than 0.6. That is one positive finding right there, and that would automatically lead us into exudative effusion. But let's say that we go a step further, and we say, okay, we check the pleural LDH, and we compare it to the serum LDH, but what we want to do is we want to know how much greater is the pleural LDH in comparison to the serum LDH with respect to its upper limit of normal. If it is greater than 2/3 the upper limit of normal of the serum LDH, that is a positive finding for that Light's criteria, makes us think exudative. But let's take it a step further. We say, okay, we check the pleural protein and we compare that to the amount of protein that's present within the serum. If we compare these two, and when we do, we get a ratio of greater than 0.5, that is also a positive finding for Light's criteria. It makes us think exudative effusion. So any of these are positive, you go to exudative. If they're negative, it's transudative. And then again, you start thinking, could it be cirrhosis? Could it be nephrotic syndrome? Could it be CHF? Those are the basic concepts that you go through here. So again, LDH to serum LDH ratio greater than 0.6. Pleural protein to serum protein greater than 0.5. If the pleural LDH is greater than 2/3 the upper limit of normal of the serum LDH, that's also a positive finding. Now, if these are positive, then you know the cause here is that these capillaries were permeable for some particular reason, causing fluid, causing proteins, causing cells, causing all these things to accumulate within the pleural cavity. The problem is, though, is you don't know what is the inflammatory cause that led to this protein, cells, and fluid accumulating within the pleural cavity. That's when you got to go back to the etiology. Is it an infection? Is it a malignancy? Is it some type of collagen vascular disease? Is there systemic inflammation? Is it a pulmonary embolism? You got to go through all of that thought process. So let's go through that now. One of the first things is, could it be a malignancy? If you look at their chest x-ray, you look at the CT, you see a big mass, and it's near the lung pleura. likely that's it, but we can't guarantee that. Obviously, I need to go and biopsy that. But if there's a pleural effusion that's near the periphery, guess what I could also do? Do a thoracentesis, and when I check that thoracentesis and I get my samples off, send it off to do cytology. Because if I do the cytology and it comes back, oh, that's an adenocarcinoma, oh, that's a large cell carcinoma, boom, I know that that's likely the cause. And if I really needed to, I could do a pleural biopsy. But that's one big thing. Send off cytology to find the malignant cells in that pleural fluid. Because again, what leaks into this? Protein, fluid, and cells. Some of those malignant cells may shed right into this pleural cavity. So look for that. Another big thing is check the actual glucose. So you check a couple different things. You check glucose within there. You obviously check the LDH and the proteins. You'll check the pH. You'll do cultures. You'll do cytology. You'll check a couple other things. But one of the big things is glucose. If the glucose is really low, less than 60, also think about malignancy. I'm going to teach you a mnemonic down at the bottom that's very high yield. Whenever you see a low glucose less than 60, to think about these 4 causes. I'll tell you about that later. But for malignancy, you think that's the cause, cytology is the big answer. Look for low glucose as well. The next thing is, what if they have a pneumonia that's right in that area, but they have an inflammation nearby? So they have what's called a parapneumonic effusion, right? But there's no infected material. It's a sterile effusion. Lots of proteins, lots of fluid, exudate, maybe even some white cells, but no infected material should be in there yet. A parapneumonic effusion will have lots of white cells that will accumulate in the area. They'll have negative cultures. It's not an empyema. There shouldn't be a ton of bacteria in there that's causing a pus accumulation like an empyema, but their pH will be low. So if you see that these patients have a low pH, less than 7.2, they have negative cultures, but they do have a lot of white cells in them, that will make you think about a parapneumonic effusion, especially on their chest x-ray CT, you see a big pneumonia. All right, so we had a parapneumonic effusion, now we have an empyema. So an empyema is where they had a localized pneumonia here, but some of that actual infection or abscess kind of spread into the pleural cavity. So now you have bacteria, white cells, all that pus-like material that's developed inside of the pleural cavity. In comparison to a parapneumonic effusion, that's a sterile inflammation. That's inflammatory material and white cells that'll be there. In this situation, there's inflammatory material and infection. So if I were to go ahead and test this, guess what? There'll be lots of white cells. There'll be a low pH, less than 7.2. There'll be a low glucose because the bacteria are going to be chewing up that glucose, so it'll be less than 60. But what's the big difference here? Positive cultures, negative cultures whenever I test that. So I check a gram stain in culture, positive, gram stain culture, negative. Parapneumonic effusion, empyema. But again, so far you've noticed low glucose, low glucose. So malignancy, empyema have low glucose. All right, next one, tuberculosis. So for tuberculosis, this is a big one. So obviously if you look at a chest x-ray and you see, and then also a big thing, empyema, if you look at a chest x-ray CT scan, you'll be able to see a big empyema, a big area of kind of like loculated infection. Same thing, if you see TB, you see like a cavitary type of lesion there on their chest x-ray or CT near the periphery, and they have an associated pleural effusion. You do the fluid analysis and you find that they have increased white cells. But here's the key. Parapneumonic effusion empyema, it was polymorphonuclear leukocytes. That's neutrophils. For TB, it is lymphocytes, that's T cells. Big difference there. Also, if I check the culture, I'm really checking for like culture against TB, the mycobacterium. So acid-fast bacillus staining, I could do that. I could also check like a PCR. Look, low pH, low glucose, low pH, low glucose. Positive cultures for actual specific bacteria other than TB, look for acid-fast bacillus. Increased white cells, lymphocytes. Increased white cells, neutrophils. Big kind of difference there. All right, we've kind of ruled out these. And again, you've noticed low glucose for TB, low glucose for empyema, low glucose for malignancy. Don't worry, I got a mnemonic to help you though. Next thing is collagen vascular disease. This includes RA, SLE, Churg-Strauss, Wegener's, all those things that we talked about. For these patients, when you test the pleural fluid, it's again due to inflammation of the parenchymal lung tissue due to antibodies attacking it. So these antibodies that are moving through the serum and attacking the lung tissue, that's one big kind of cause here. Now, first thing is if they have low glucose. Whenever you check the fluid and they have low glucose, you should think about this disorder as a part of the collagen vascular diseases. Think about rheumatoid arthritis. Huge, huge thing. Please do not forget that. If they have low glucose, less than 60, think about RA. What you could do then is there's not really much else that you're going to get from the pleural fluid analysis. Check a serum ANA with reflex, check a rheumatoid factor, and then also check the serum ANCAs, because what you're doing is you're checking for all those antibodies. So you're checking for the ANAs, for lupus, you're checking for rheumatoid factor, for RF, rheumatoid arthritis, you're checking the ANCAs for Wegener's, which is going to be the P ANCAs, and then again C ANCAs, and then for Church-Strauss, you're checking for the P ANCAs. So that's the whole point, is you're checking for the antibodies in the serum. If you have a collagen vascular disease where you have a low glucose less than 60, send off these serum labs. You're not going to get this from the pleural fluid. You're going to have to check the blood for that. Okay? But right away, you see glucose less than 60, think RA. So send off these serum labs reflexively. What are some other causes? Another one is if I test this fluid and I go ahead and I test it for lots and lots, it looks milky. I think that's one of the key words that you really want to think about here is I see that term milky. When I take and I pull off the fluid and I see it looks like milky, that should make you think about a chylothorax. If it looks very milky type of appearance, send it off to check triglycerides and check cholesterol. If they have a very, very high triglycerides and high cholesterol, boom, you have a chylothorax. The last one here, not super heavy, but if a patient has pancreatitis, you know, whenever they have pancreatitis, there's a specific enzyme that maybe leak into the actual bloodstream and kind of maybe leak into the pleural cavity here. It's called amylase. So you have amylase and lipase and proteases that are made by the actual, the pancreas. If the amylase is really, really heavily kind of concentrated in the pleural cavity, and the ratio between the pleural amylase, the amylase inside of the pleural cavity in comparison to the serum amylase, is greater than 1, you should be thinking about 2 disorders. There's a lot of inflammation coming from the pancreas, so pancreatitis. But guess what else? Guess who else makes amylase? Our salivary glands. So if our salivary glands make amylase, and the amylase goes down through our esophagus, and we have a hole in our esophagus, and some of that leaks right into the pleural cavity, that could be another particular reason. So think about esophageal rupture if the actual pleural amylase is greater than the serum amylase by at least 1, the ratio 1, okay? Think about pancreatitis or esophageal rupture. Easy to be able to kind of differentiate these based upon the clinical features of pancreatitis and then imaging. All right, my friends. We have one last thing to talk about, which is I see low glucose on my thoracentesis kind of analysis. What are the etiologies to think about? Well, we already got malignancy. We got empyema. We got rheumatoid arthritis is one of the big ones. And then tuberculosis. Well, go ahead and remember MEAT. Malignancy, empyema, arthritis, rheumatoid arthritis, and then tuberculosis. This is a high yield fact to think about when you present this on your exam. All right, let's talk about the treatment now of these pleural disorders. All right, so when we talk about pleural diseases and treating them, it's pretty straightforward. Not gonna go too crazy. They're not gonna be too high yield for your exam. So first thing is whenever you have a patient who has a pneumothorax, you wanna differentiate, okay, is it primary, secondary? All right, is it a tension pneumothorax? And are they having recurrent pneumothorax? So those should be the 4 questions you ask. Primary, secondary, tension, or recurrent. For a primary pneumothorax, generally, if they're small, patient's asymptomatic, you just leave it alone. You observe, see if it just resorbs on its own. Okay? Generally, some supplemental O2 may help to be able to resorb some of the oxygen or the nitrogen out of that actual pneumothorax. So that might be a helpful thing to do. If it's large, the patient is having symptoms, they're having some of the symptoms that we talked about, then you can consider trying what's called a needle aspiration. So if it's not too big, but you can stick a needle into the area where you actually see the pneumothorax and pull some of the air out to decrease the air within that pleural cavity, that might be an option. And if that isn't an option, you can just stick a chest tube in there and allow for that to drain over time. Supplemental O2, again, will be helpful throughout this entire process to resorb some of the air out of the pneumothorax and into the alveoli. If it's a secondary pneumothorax, generally those patients have underlying lung diseases. They have some type of underlying traumatic cause or iatrogenic cause. Chest tube, generally that's the best goal there. So chest tube for a secondary pneumothorax with supplemental O2. Now, if it's a tension pneumothorax, so you have the patient with visible signs of tracheal deviation, absent breath sounds or very, very diminished breath sounds on the affected side of the tension pneumothorax, they have JVD, they have hypotension, they have tachycardia, all of those findings that would support a tension pneumothorax, you immediately needle decompress in the second intercostal space midclavicular line, followed by a chest tube, and the 4th to 5th intercostal space, usually between the anterior and mid-axillary line, would be the place where you'd put the chest tube. And for the last situation here, my friends, is if a patient's continuously getting pneumothoraxes, what you could consider is actually obliterating the space. And so how you could do that is you could do two things. One is you could have like a little chest tube, and when you have the chest tube, what you do is you push through the chest tube some very harsh chemicals that'll induce a fibrotic reaction. And this fibrotic reaction, what it'll do is it'll help to be able to kind of like cling the visceral and the parietal pleura together so that you aren't able to separate them anymore. And so you can use things like talc, doxycycline, silver nitrate. Those might be some of the options that you could put in there to create a fibrotic reaction. If that doesn't work, you can actually go in there, open it up, and then go in and actually scrape the actual visceral and parietal pleura and create a fibrotic reaction that way. All right, so that's how we would treat the pneumothorax. Let's talk about pleural effusions now. All right, so for pleural effusions, if a patient has fluid within the pleural cavity, it's pretty straightforward, right? You want to figure out, is it transudative or is it exudative? If it's transudative, that's usually due to, most common cause, CHF. CHF is going to be the most common cause. Left-sided venous pressures, back into the pulmonary circulation, increased hydrostatic pressure, fluid accumulating there. So what can I do? Treat the underlying problem. So treat their CHF is obviously the best thing, but I can restrict some sodium and I can diurese some of the fluid off of them. And if I do that, that may actually alleviate their pleural effusion. Now, if you're trying to diurese and diurese and diurese and you're intravascularly depleting them and it's not working and they're refractory to diuretics and sodium restriction and they're having worsening shortness of breath, then you can actually stick a needle in and drain some of the fluid off if it's large enough and causing compression there. You could do a thoracentesis. Now, for exudative effusions, you have to figure out the underlying cause and treat that. The big ones that I think that they could test you on, though, is if it's a parapneumonic effusion that creates a sterile, localized inflammation, white cells, low pH, right? Lots of inflammatory mediators, but no infection there. It's the infection of the lung tissue, not the pleural fluid. In that situation, treat the pneumonia. The parapneumonic effusion will resorb over time. If it's an empyema, antibiotics are not going to be enough. It'll treat the actual infection, but we have to get to this. And the only way we can get to this is to stick a tube into that area. So we'll stick a tube in and drain that area. And sometimes we either have to open them up, we may have to do an open drainage, or you know what is a really cool thing that they might test you on? Sometimes you put a chest tube in and put TPA into the chest tube, into their pleural cavity, because it'll break down all the fibrin strands within that loculated empyema and allow for it to drain if it's not draining. Okay, so big things that you need to know, especially empyema, antibiotics will not be enough. You have to stick a tube in there, drain it, and sometimes you may need to give TPA to actually drain that properly. But the ultimate thing is, treat the cause. If it's a PE, you have to treat the PE. If it's a collagen vascular disease, you need to give them steroids or immunosuppressants, right? If it's a malignancy, you have to treat the underlying cause of the malignancy, whether it be surgery or chemoradiation, whatever. But those are the big things that you have to know. But I think the most important ones that are relatively reversible is a parapneumonic effusion and an empyema. The last thing is, what if somebody continues to develop recurrent pleural effusions? Usually you see this with like collagen vascular diseases because they have repeated attacks, or a malignancy because it's not being treated and they continue to develop these pleural effusions. If it's recurrent, it's malignant pleural effusions, you can obliterate the pleural space just like we did with a recurrent pneumothorax. How do we do that? We can stick a tube into the actual pleural cavity. When we stick a tube into the pleural cavity, we introduced chemicals that will produce a fibrotic reaction. Silver nitrate, talc, doxycycline. Fibrosis will obliterate the cavity. You can't form fluid there. Or we can go in surgically and create a, kind of like agitate the actual visceral and parietal pleura and create a fibrotic reaction. But that's the way we would treat pleural effusions. Let's talk about the last thing, atelectasis. All right, so with atelectasis, you have to remember we treat the cause. Okay, so if someone has atelectasis on their chest x-ray, their CT scan, we see that as the potential cause for their problems, maybe some degree of hypoxemia, tachypnea, etc. Then what we can do is we treat the cause. If it's an obstructive atelectasis, there's a big fat mucus plug, there's a tumor, there's a foreign body that is stuck somewhere here in that main bronchus, I need to do a bronchoscopy, stick a camera down there and pull that actual mucus, suck the mucus out, remove the tumor, remove the foreign body, whatever it may be, so I can open up the airway and allow for it to ventilate those alveoli. Straightforward. If it's a compressive atelectasis, my friend, so now I have a patient who has a fluid accumulation in here, or maybe it's not fluid, maybe it's air. So they have a pneumothorax, they have a pleural effusion, it's compressing the alveoli, compressing the lung tissue. I treat the underlying cause. I do a thoracentesis if it's a big whopping pleural effusion to decrease that, or I put a chest tube in, or needle aspirate if it's a pneumothorax to be able to pull some of the air out so it's not compressing on the lung tissue. Pretty straightforward. Now here's the interesting one. This is the one that you're most likely to see, especially on your surgical rotations, is after somebody has surgery, they're in a lot of pain, they don't want to really take deep breaths in, they don't want to cough because everything hurts when they take a breath in or when they cough. So one of the best things, and also they're laying down flat. You know when you lay down flat, what that does is that pushes the actual diaphragm up because all the abdominal contents are going to push the diaphragm upwards. And if you push the diaphragm upwards, it's going to compress on the actual lung tissue, making it harder to be able to ventilate them. So when patients are bedbound after surgery, they're in a lot of pain and they don't want to cough because it hurts, they don't want to breathe because it hurts, guess what you should tell them to do? Well, first thing, treat the pain so it's easier to breathe so they can take deeper breaths. Tell them to be able to take deep breaths consistently so that they can keep trying to ventilate those alveoli. Tell them to cough, because if mucus accumulates within their airways because they don't want to cough, guess what? It can plug them up and they can develop atelectasis. The other thing is getting them up out of bed, or at least sitting in a chair so that the diaphragm is not pushing up on their actual lungs, it's down. And so if I have them standing up or have them sitting in a chair, it'll bring that diaphragm downwards, not compressing on their lungs as much. So getting them up out of bed, ambulating is a really good thing as well. Lastly, giving them something called an incentive spirometer. So having them kind of like use this kind of device where they take a deep breath in and blow into it. And what it does, it helps to generate some PEEP inside of the lungs to be able to keep those alveoli stented open nicely. These are really big things to remember, especially in your surgical rotations and on the clinical vignettes. Last thing, something that you're probably gonna see just really quick, if the patient has severe atelectasis where multiple alveoli are collapsed, especially at the bases of the lungs where there's the most perfusion, you can develop severe hypoxemia. And in those patients, they may not respond to all of these things. And so what you may have to do is put them on some type of like mechanical ventilation, whether it be non-invasive like BiPAP to really create a lot of pressure in their airways, or unfortunately stick a tube down their airway and ventilate them mechanically and invasively. So these are things to think about. All right, that covers our pleural disorders, but now let's do some cases.
All right, my friends, let's do a case. So here we have a 62-year-old female, recent diagnosis of left lobar pneumonia, treated with antibiotics but complains she's still having shortness of breath and now with pleuritic chest pain that is worse when lying flat. So pleuritic chest pain always indicative of some type of like pleural process. So there may be some type of like, again, pleural involvement here. So this could be a pleural effusion, especially with left lobar pneumonia recently. I would be very concerned of a patient having like an empyema or a parapneumonic effusion, something of that nature. So definitely concerning when I think about that. So let's kind of further evaluate the patient. So vital is very important here. Normal blood pressure, slightly tachycardic, no tachypnea, like really that bad. Very, very, very mild if you really want to consider that. But she's febrile, so that's concerning right away. She may still kind of be responding to, this may be still reactive from her left lobar pneumonia, but I'm also very concerned now that she may have an empyema. But we'll continue to keep evaluating. And then SpO2 is 88%, so slightly hypoxic as well. We examine her chest. She's got decreased chest expansion on the left, which means that she might have difficulty being able to open up that left lung. Could that be from the pneumonia? Could that be because she's now got a big whopping pleural effusion or empyema around that? Could be. Decreased breath sounds on the left. Again, not really inflating that left lung as much. Dull to percussion. So again, that's kind of supporting more of a consolidative feature or fluid potentially within the lung tissue or around the lung tissue. And then decreased tactile fremitus. Not really supportive of a pneumonia finding, more supportive of potentially kind of like a pleural effusion. So I would say that this is definitely supportive of likely some type of pleural fluid. Whether that's infected or non-infected, I'm not completely sure yet. But how do I really kind of get started on this? I'm going to get a chest x-ray. I'm going to make sure that the pneumonia hasn't gotten worse, make sure she doesn't have any other kind of pulmonary process, especially what I think it is, which is, big, huge, fat pleural effusion there on the left side. So you can see the meniscus sign here and you can see an obvious left pleural effusion. So definitely a big one. If I really wanted to get a better look at it, I like to do bedside ultrasounds, but sometimes a CT scan is very convenient and it really gives you a good look at the entire lung tissue, the parenchyma, the interstitial spaces, as well as kind of gives you a good look at the pleural effusion, how large it is, and if it kind of looks more loculated and concerning for an empyema in comparison to like a peripneumonic sterile effusion. So I like to get CTs sometimes as well. To determine if it's an exudative effusion, so would I be very concerned of, especially with pneumonia or other types of problems such as like, malignancies or some type of like nasty infection like TB, etc., maybe even a pulmonary embolism, or is it exudated? So is it from some type of situation here where the patient has something like heart failure or they have like a nephrotic syndrome or CKD or cirrhosis, something of that effect there. And so how do I really kind of go about doing that? I'm going to tap into the left cavity there in the pleura and pull off some of that actual pleural fluid and test it. I'm going to test the pleural LDH, the pleural protein, and then compare that to the serum LDH and serum protein. So that's called the Lights criteria. And that's really going to help me to determine, is it concerning for exudative, which I'm very concerned of with her having pneumonia, or is it exudative? So I'm going to do that. What do I get? When I do this, I see that the pleural LDH is, in comparison to the serum, is 1.2. Well, anything greater than 0.6 is concerning. So that's one positive finding. Pleural protein greater than 0.5 in comparison to the serum protein is positive. So that's positive. And the pleural LDH, if it's greater than 2/3 the upper limit of normal of the serum, that's positive. She's got all findings of an exudative effusion, so this definitely seems like an exudative effusion. So if exudative, then that rules out the suspected potentially transudative effusion, such as a cardiac problem, such as CHF or a cardiomyopathy of some type of cirrhosis, nephrotic syndrome, CKD, something to that effect. Whereas it's more concerning of could this be related to, a pneumonia, so a localized pneumonia that caused a pneumonic effusion and it caused it to become infected? Could it be from some type of malignancy? Could it be systemic inflammation from like a pancreatitis? Could it be from a PE? Could it also be from some type of, collagen vascular disease that's causing like a vasculitity of some type? These are things to think about here, but at least for right now, I've ruled out the transudative causes. So now we move on to the next part here, which is if I do think that this is exudative, how do I determine which type of exudative it is? So the next thing I'm going to do is I'm going to evaluate other potential things that may lead me to think about what it could be. I'll check the pleural pH. If the pleural pH gets kind of low, it definitely supports more of an infectious potential etiology. If the glucose is really low, that's really concerning. That can point to a lot of different things. And so some of the things that you really want to think about whenever the glucose is low, especially less than 60, is think about meat. Sounds a little odd, but malignancies, empyema, rheumatoid arthritis, which is a type of collagen vascular disease, and tuberculosis. This is concerning findings if I see the glucose is really low. So if the glucose is low, the pH is low, definitely concerning for an empyema. But then check the white cells. So the white cells through the roof, especially for like neutrophils, again concerning for an empyema. Is the gram stain in culture positive? That could be concerning for an empyema. Do they have a positive acid-fast bacillus smear in culture? That could be concerning for tuberculosis. Check for any kind of like abnormal kind of like malignant cytology that could point towards a malignancy. And again, think about other things like, do they test positive on ANA and they're kind of like ESR, CRPs elevated, they have some concerning factors of rheumatoid arthritis. That obviously could be something to think about. And then if you are concerned that they may have a chylothorax, check the triglycerides. And if you're concerned that they have a pancreatitis, then you can check their amylase as well. But these are things that we could go about kind of trying to figure out if we're really concerned about what type it is. Oftentimes getting these things and then kind of gathering all the information is going to be key. With this patient, I'm very concerned that they have an empyema. And so when I look at theirs, I need to just figure out, does their gram stain come back positive? And do they have any kind of cultures that grow any bacteria? Is their pH low? Is their glucose low? Is their white blood cells high? And so how do I kind of go about doing that? Well, let's kind of see if you can determine based upon these findings what we would suggest. So if a gram stain is negative and there's really no kind of culture growing any bacteria, but they do have some polymorphonuclear leukocytes, there's some white blood cells there, this could really support kind of like a parapneumonic effusion, so nothing really special. If the gram stain in culture is positive, they have a low glucose, a low pH, and it's very purulent appearing, that is very concerning for an empyema. If you go into the next thing, which their PCR acid-fast bacillus stain in culture are positive, so that's for tuberculosis. Their pleural lymphocytes are high, so not as much as their, there's more lymphocytes in their actual pleural fluid in comparison to like neutrophils, and their pleural glucose is low. That's concerning for tuberculosis. And if their pleural amylase is really elevated in comparison to the serum amylase, that would be supportive of a pancreatitis. Again, you could also think about an esophageal rupture, again, because the reason why is the salivary glands also make something called salivary amylase. So if you make salivary amylase and they have an esophageal rupture and it leaks out into the actual mediastinum or in the pleural area, it could be esophageal rupture, but it also could be pancreatitis whenever they have that. The pancreatic amylase can actually circulate through into the lungs as well. So, it doesn't really point towards which one in that situation, but it tells you about there's one of these etiologies. The next thing is if the pleural triglycerides are greater than 110, that's really, really high, think about a chylothorax as a potential etiology here. And then I think the big thing for this patient is, what do we think that she has? Hers actually came back as positive gram stain in culture. She had purulent appearing, kind of like a pleural fluid. She had a pleural glucose less than 60 and her pleural pH was less than 7.2. So with her pneumonia, definitely supports an empyema. So we need to actually put in a chest tube and drain that kind of like actual nasty empyema fluid. Sometimes we actually have to use something called intrapleural TPA, where you actually push TPA into the pleural cavity, and the TPA will actually break down some of the fibrin strands that are within that loculated empyema, and then put them on very strong IV antibiotics to help to kill the infection. So that would be covering that case. So case study number 2, you had a 62-year-old male. Past medical history is pertinent for emphysema. They're on a ventilator for airway protection, so they ended up having a very large ischemic stroke. Maybe their GCS was really, really low. They weren't able to maintain and protect their airway, and so they were intubated subsequently. They also were noted to have a right subclavian central line that was placed because the patient needed to be on pressors for whatever reason. Maybe they were septic, maybe they were pushing the blood pressure up because they needed to perfuse the brain because of the stroke, whatever it may be. And then they also had a lot of atelectasis that was noted on their chest x-ray, and the RT increased the PEEP to kind of really stent open those airways. Whenever they did these things, they noticed that the patient developed acute hypoxia and associated hypotension. This is a terrible situation here. I'm a big fan. I work in the ICU, so I like to place a lot of subclavian central lines, but this is concerning for potentially a pneumothorax here. So when we look here, the patient's BP is in the oh my gosh, it's in the dookie, right? So 70/44, they're on norepinephrine at 30 mics. So that's a very high dose of norepinephrine on this patient. So very concerning. I'd say that that's a concerning finding for, very poor kind of like situation here. Heart rate is 148, so she's tachycardic. She's also breathing at a rate of 30. Oh, he is breathing at a rate of 36, so he's tachypnic. Temperature is okay, and they're on 80% SpO2 with FiO2 of 60% on the ventilator. So not a good sign here. So they are hypotensive and shock state, kind of with norepinephrine on, tachycardic, tachypnic, and severely hypoxic. So with this being said, I'm definitely concerned for a tension pneumothorax in this patient. When we go and we examine them, because this is a diagnosis, a clinical diagnosis, you don't need a chest x-ray to determine this, but you go, you listen to the side where they perform the subclavian line. You don't hear any breath sounds on that right side. So no expansion of the chest on the right side. You hear complete tympany or dullness to percussion on that right side. They have decreased tactile fremitus on the right side. Their jugular vein is just severely kind of like enlarged and distended because all of their lung is actually smashing and shifting their entire mediastinum towards the left, so it's compressing their right atrium and their superior and inferior vena cava. And then on top of that, it's shifting the mediastinum to the left, such as the trachea, and the trachea is deviated to the left. These things are supportive, especially in this clinical context of a tension pneumothorax. So you wouldn't need a chest x-ray, but you should, and then you can get a tension pneumothorax as the likely diagnosis. But what do you think caused it? I think it was probably the right subclavian central line, but it also could be due to whenever you try to increase PEEP, you increase airway pressures, and sometimes that's enough to be able to kind of pop open one of those alveoli. So that's likely the potential cause there. What are some other causes, though, of a pneumothorax? I think it's important to remember. Is it a primary? Is it a secondary pneumothorax? This would be a secondary pneumothorax because primary is usually in those tall, thin, skinny males who are smokers, maybe a history of Marfan syndrome. Whereas secondary, it's usually due to some type of problematic issue where they have hyperinflation of their lungs, like COPD, bronchiectasis, they have asthma, or it could be due to malignancies. So again, malignancies actually kind of eating their way through the pleura or involving the pleura and actually leading to air leaking into the pleural space, or necrotizing infections and that actually kind of leak into the pleural space. It could also be due to trauma, whether it be external or internal trauma. So that could be due to things such as, if I got hit in the head with a tomahawk, I'm going to have an opening of my chest, which allows for air to leak in. Or if I am, ventilating the patient with very large amounts of PEEP, that could be a potential cause. If I'm putting a central line in the area and I'm poking the lung from the outside, if I'm doing a thoracentesis to drain off some of the pleural fluid in the patient in the last case, and I end up hitting the lung, that could also drop the lung and cause a pneumothorax as well. So a lot of things can definitely cause this. So if you get a chest x-ray, what do you potentially see here? The biggest pneumothorax you've ever seen. Look at this. This is gargantuous. So huge right pneumothorax. They obviously didn't complete the right subclavian central line at this point in time. But anyway, they got this big right pneumothorax in this potential part of the chest. So we're going to see that. We're going to see tracheal deviation, mediastinal shift. So pretty significant kind of like pneumothorax. So how do we treat them? They're already on oxygen, so continue, put them on 100% FiO2, very large amounts of FiO2 because that may be able to suck some of the actual nitrogen out of the actual pneumothorax, which is actually really helpful. I would also lower some of the pressures inside of the chest, so lower the PEEP, lower the airway pressures, and then I would immediately needle decompress. So generally you don't have to do this, but you can immediately needle decompress them in the second intercostal space, but I would just go straight to the chest tube and shove it into the fourth and fifth intercostal space along the actual kind of anterior mid-axillary line. Okay, whereas if you're going to needle decompress them, it's usually a mid-clavicular line. So this is how I would do it, except it would be on the right side. So you'd stick it here on the right side, don't do it on the left one. Stick it on the right since that's where they actually have the pneumo, right second intercostal space, mid-clavicular, or fourth, fifth intercostal space for the chest tube, or mid-axillary line. Okay. All right, case study 3, you got an 80-year-old male. They just got extubated. In other words, they removed the endotracheal tube and they were off the ventilator. After having a very traumatic brain injury, they developed difficulty being able to kind of manage some of their secretions. So some of the secretions may be kind of aspirating a little bit of it. They develop hypoxia, but they're responding appropriately to oxygen supplementation. So you put oxygen on them and their actual SpO2 improves. So if we look here, I wouldn't say that's a great SpO2, but we see here their BP is 100/64, their heart rate's 118, respiratory rate's 38, temperature not febrile, SpO2 is 70% on FiO2 of 40%. That's not a very good response, to be honest with you, but I think if you give them time and they say that they're actually responding to oxygen supplementation, it must bump up at some point in time. But either way, kind of a concerning sign to see that they're actually having this particular issue here. Generally, whenever a patient has a very severe mucus plug in the upper airway, though, like for example, if you had like a right bronchus or a left bronchus, kind of like complete obstruction of the actual bronchus, you're not going to respond to oxygen supplementation. Oftentimes, they have severe hypoxia. So, and that doesn't usually improve because you have a big fat plug that's blocking oxygen going into there. So I suspect that's the actual correct thing here. So this is likely, hypoxia that is not responding to oxygen supplementation. But we examine the patient. They have a decreased chest expansion on the right side. So they're not moving that right chest. Tells me that they probably got a big kind of like mucus plug in their right bronchus is my suspicion. They got decreased breath sounds on the right. So again, they're not inflating that right lung because they have probably a complete kind of obstruction, kind of not allowing for air to get into the lung. They have hyperresonance to percussion on the right side. They have decreased tactile fremitus on the right, and the trachea is deviated to the same side as where there is decreased chest expansion. Again, supporting more of an atelectatic process. So I think it's atelectasis, but I think it's due to a mucus plug. I think they got a big mucus plug in their right bronchus, and that's the likely cause that they're not getting air into that right bronchus. And again, if you can give them FiO2, 100% and they don't improve, it kind of supports a very significant atelectasis. So I think it's a mucus plug that's likely in the right main bronchus. So if we were to go ahead and get like a chest x-ray, we would be able to find that. But there's many other causes of atelectasis. It could be obstructive. In this case, I think it is obstructive. They could have a tumor. They could have a foreign body, like a big old peanut stuck within the right bronchus. They could have a mucus plug because they're not able to manage their secretions. Sometimes it can be due to compression, so pleural fluid or pneumothorax within the side of kind of pleural cavities pushing down and squeezing on the actual lung. It could be due to adhesive, so you have a lack of surfactant in situations of acute respiratory distress syndrome or infant respiratory distress syndrome, and it can also be due to a lot of like fibrosis that actually is causing like a contraction or squeezing down of the alveoli in interstitial lung disease. So I'd say these are the two most common though that you're going to see obstructive and compressive atelectasis. So I'd say this is an obstructive atelectasis. If you get a chest x-ray, you're likely going to see, you see the big atelectasis here on the right side. They're not inflating this kind of like right middle lobe and probably even some of the right lower lobe. And so it's just completely collapsing because it's not getting filled with air. So I would say that that's the case. And plus they're probably going to have tracheal deviation to the same side because they're losing some volume on that side. So how do we treat them? For these patients, generally just bronch them or try to suction up the actual secretions in that right side of the lung. But generally, kind of an oral like Yankauer suction isn't going to be enough. Sometimes you can try to do a nasotracheal suction, but oftentimes you have to put down a tube down the airway and do what's called a bronchoscopy and suction some of that mucus from the bronchus to improve them. How do we really prevent atelectasis, which is really what's the key here? Generally, it's kind of like deep breathing, coughing, incentive spirometry, getting them out of bed and walking around. Those are usually the best things. And then if they are in any pain and they're not taking deep breaths, giving them kind of like pain medications to treat their pain will also be helpful, because if you're really in a lot of pain because you just got a belly surgery, you're not going to want to take a deep breath in, and then you don't actually ventilate and kind of like plump open those alveoli, and so they kind of start collapsing. So that could also be causes. So get them to cough, get them to deep breathe, use the incentive spirometer to try to be able to kind of suck air in and blow air out. And then getting out of bed is really, really key here. All right, my friends, that covers this lecture here on a lot of the pleural disorders, covering like pleural effusions, covering pneumothorax, and covering atelectasis. I hope it made sense. I hope that you guys enjoyed it. And as always, love you, thank you, and until next time.